Welcome to the Health Headliner podcast by Tudu Digital. Our content is informational only and not medical advice. Please consult your provider. Now, let's dive into today's headlines.
Think about those times when a health issue just feels like,
Mm.
well, like a total guessing game.
hmm
You're trying to figure out what's going on, what might happen next, and it can be just so frustrating when the answers aren't clear.
Absolutely. That uncertainty is a real burden.
And that feeling, that uncertainty, it gets really amplified when we talk about systemic sclerosis. Sometimes people know it as scleroderma.
Yeah.
It's such a tough condition because it really hits everyone differently. For some, maybe just skin changes.
Right.
But for others,
Yeah.
it can lead to really serious problems with internal organs.
It can be devastating.
And what's really sobering is that, well, compared to other autoimmune conditions people might know better, like rheumatoid arthritis or lupus, scleroderma, unfortunately, often comes with a higher mortality risk.
That's right. It has the highest case fatality rate of all the autoimmune rheumatic diseases. It really underscores why understanding it better is so vital.
It really does.
Yeah.
And that challenge, that variability, is exactly where our deep dive takes us today. We're looking at some fascinating new research just published in the Lancet Rheumatology.
Oh, okay.
It explores a potential blood biomarker, something that might help spot patients with a specific, more severe type. It's called diffuse cutaneous systemic sclerosis, who are at a higher risk for worse outcomes.
That sounds incredibly important. A step towards more targeted help, maybe earlier.
Exactly. Feels like it could be a really significant step towards getting the right interventions to the right people sooner.
It certainly sounds promising. Maybe we should quickly clarify what systemic sclerosis actually is, just for context.
Good idea.
So fundamentally, it's an autoimmune disease. The body's own defense system mistakenly attacks healthy tissues.
Right.
And this leads to this characteristic hardening and thickening, usually of the skin, but also the connective tissues, the stuff that supports our organs and other body parts.
And it's not just skin deep, is it?
No, not at all. That's the critical part. It can affect vital organs, the heart, lungs, kidneys, the digestive tract. It can become systemic, as the name suggests.
Okay. And you mentioned there are different types. The study focuses on one specific type, diffuse cutaneous systemic sclerosis. How does that differ from, say, the limited type?
Right, that's a key distinction. So limited cutaneous systemic sclerosis mostly involves skin thickening below the elbows and knees, maybe the face and neck. It generally progresses more slowly, and the organ involvement might be less severe, often appearing later.
Gotcha.
Diffuse cutaneous systemic sclerosis, on the other hand, tends to involve skin thickening above the elbows and knees, maybe on the chest or abdomen too. It often comes on more rapidly, and there's a higher risk of significant internal organ involvement, particularly early on.
So that diffuse type is generally linked to a tougher prognosis.
Generally, yes. That's why being able to identify not just who has the diffuse form, but who within that group is likely to have the most aggressive disease course. Well, that's a huge goal in the field.
Got it. Okay, so for everyone listening, our mission today is to really unpack this new research. We'll explain this potential blood marker, what the study found, and what it could mean for managing severe scleroderma.
We'll try to keep it clear, focus on the key takeaways.
Yeah, no getting bogged down in excessive jargon. The real focus is, how might this help us find those highest risk patients earlier and maybe get them more intensive treatment when it counts most?
Exactly. So let's dive into the study itself. What were they trying to achieve?
Well, the main purpose, as I understand it, was to find a reliable blood test, a marker, that could predict poor outcomes in patients who were in the early stages of that diffuse cutaneous systemic sclerosis.
Right, catching it early is key. And how did they go about that? They looked at patient groups.
Yes, two main groups. Can you walk us through those?
Sure. The first was called the United States Prospective Registry of Early Systemic Sclerosis. Let's call it PRESS for short, though we'll try to avoid acronyms.
Okay, the press group.
This was what they call an incident cohort. It included 110 patients who had recently developed diffuse cutaneous systemic sclerosis. They were recruited from 11 different academic centers across the U.S., starting back in 2012.
So people newly diagnosed.
Pretty much. The criteria involved having swollen hands or that tight, thick skin on the fingers, plus other signs like specific antibodies or skin thickening further up the arms or on the torso, or something called tendon friction rubs a kind of grating feeling a doctor might detect.
Okay, any exclusions?
Yes, they excluded patients with a specific antibody called anticentromere antibody, which is more linked to the limited form, or if they'd already had the diffuse diagnosis for over 2 years. They wanted that early window.
Makes sense. And what were these patients like demographically?
The average age was around 50, mostly women, about 69%, and predominantly white, around 79%. So that gives us a picture of the early stage group.
Okay, one group down. What was the second one?
The second was the STRIKE group that stands for Stratification for Risk of Progression in Scleroderma. This one was based in the UK.
Strike. Okay. Different from press.
Yes, this was a prevalent cohort. It included 72 patients who already had a diagnosis of diffuse cutaneous systemic sclerosis, recruited between 2014 and 2018, so potentially people who'd had the disease a bit longer.
All right. And they had a comparison group too.
They did. For the STRIKE cohort, they also recruited 32 healthy volunteers to serve as a baseline, a control group.
And the strike patients. Similar demographics.
Quite similar, actually. Average age around 52, again about 69% women, and even higher proportion white, 89%. The healthy controls were fairly similar to average age 47, 59% women, 75% white.
So two distinct patient groups, one early, one more established, plus healthy controls. Now the crucial part, how did they look for this blood marker? What were they measuring?
They focused on a set of immune signaling molecules called type 1 interferons.
Interferons. I've heard of those. They're involved in the immune response, right?
Exactly. They're key players in cell communication and defense, and there's already quite a bit of research suggesting a link between type 1 interferon activity and various autoimmune diseases, including systemic sclerosis.
But measuring them directly is tricky.
Very tricky. They're usually present in really low concentrations in the blood serum, so the researchers took an indirect approach.
Okay, how do they do that?
Instead of trying to measure the interferons themselves, they measured the levels of 6 other molecule-specific chemokines that are known to be produced in response to type 1 interferon activity.
So like measuring the smoke to know there's a fire.
That's a good analogy, yes. These chemokines, the specific ones were CCL2, CCL8, CCL19, CXCL9, CXCL10, and CXCL11 are easier to detect, and their levels reflect how active that type 1 interferon pathway is.
So they measured these 6 chemokines.
Correct. And based on the levels of all 6, they calculated a combined score, which they called an interferon score, a single number representing that overall type 1 interferon activity level.
Okay, an interferon score. And how did they use that score to group the patients?
They compared the patient scores to the scores of the healthy control group. They established a cutoff point. If a patient's score was notably higher than the average in the healthy control specifically, a score of 5.5 or more, based on their calculation, they were classified as interferon high.
And below that was interferon low.
Exactly. It was a way to sort patients into 2 groups based on this measure of underlying immune system activity, specifically related to type 1 interferons.
Right, identifying those with that potentially higher immune alert status. Okay, so they've got their groups, they've got their interferon scores. What did they actually find? What were the key results?
Okay, let's look at the press group first, the early diagnosis cohort.
Right.
What they found was pretty significant. Patients who were classified as interferon high right at the beginning of the study generally had worse lung function.
Worse lung function. How did they measure that?
Through standard lung tests. Specifically, lower forced vital capacity. That's a measure of how much air you can forcefully exhale, and also lower diffusing capacity for carbon monoxide, which reflects how well the lungs transfer gas, like oxygen, into the blood.
So objective measures of lung health were worse in the high group.
Yes. And not only that, these interferon high patients also reported more physical disability based on a standard questionnaire called the Health Assessment Questionnaire Disability Index.
And did these differences last?
They did. The researchers followed these patients for a median of about 34 months, almost 3 years, and those differences in lung function between the high and low interferon groups persisted throughout that time.
Wow. So this score at the start seemed to predict a sustained difference in lung health down the line. That seems really important for an early stage group.
It really does. It points towards this score potentially being an early indicator of a more severe disease trajectory, particularly regarding the lungs.
Okay, what about the other group, the strike cohort, with a more established disease? Did they see similar things?
Broadly, yes. In the STRIKE group, patients with high interferon scores also had worse lung function compared to those with low scores, and again, this difference seemed to persist during their follow-up period as well.
Okay, So a consistent finding across both early and more established disease regarding lung function.
Yes. Interestingly, though, in the strike group, the interferon high patients actually had a shorter median disease duration, about 2.2 years since diagnosis, compared to 5 years for the interferon low group.
Huh. That's interesting. Any thoughts on why that might be?
Well, it's hard to say definitively from the study alone, but it could suggest that maybe a higher interferon signature is associated with a more rapid onset or progression, meaning those individuals perhaps came to clinical attention or were diagnosed sooner, even if their outcomes were ultimately worse. But that's speculation.
Okay. Did they look at mortality?
Yeah.
The risk of death?
They did. They combined data from both cohorts, focusing specifically on patients diagnosed within the last 2 years to look at survival over a 5-year period. They observed a trend. It wasn't statistically significant in all analyses, but a clear trend towards higher mortality in the interferon high group. The rate was around 24.9% in the high group versus 8.6% in the low group over 5 years.
That's a substantial difference, even if it's a trend.
It is. And given that scleroderma-related lung disease is the leading cause of death for these patients, that link between the high interferon score, worse lung function, and potentially higher mortality, well, it really starts to paint a concerning picture for that interferon high group.
Absolutely. It really drives home the potential significance of these findings. Let's really unpack those implications now.
I think the biggest one is clearly early identification.
Right. Being able to spot trouble earlier.
Exactly. If this interferon score holds up in further studies, it could become a crucial tool for doctors to identify much earlier on which patients with diffuse scleroderma are heading towards more severe disease progression.
And that early warning could mean?
It could mean starting more aggressive treatments much sooner, potentially before irreversible organ damage, especially to the lungs, occurs. It could shift the whole treatment paradigm.
Which leads nicely into the idea of personalized medicine, doesn't it?
Precisely. Instead of a somewhat standard approach for everyone with diffuse disease, doctors could use the interferon score to tailor the treatment intensity. High score, maybe you get the stronger therapies right away. Low score, perhaps a less aggressive approach is warranted initially with close monitoring.
Tailoring treatment based on individual risk profiles.
That's the goal. It could make treatment much more effective and potentially safer, avoiding overly aggressive therapy in those who might not need it.
Could this score be useful for monitoring too, not just at the start?
That's another potential application. Could tracking changes in the interferon score over time give doctors a better handle on how the disease is behaving? Is it getting more active? Is the treatment actually dampening down this interferon signature? It might offer a way to monitor disease activity and treatment response beyond just clinical symptoms.
Like another piece of the puzzle when managing the condition long term.
Exactly. And it also ties into drug development.
How so?
Well, this research adds weight to the idea that targeting the type 1 interferon pathway could be beneficial. There's actually an ongoing clinical trial right now investigating a drug designed to block type 1 interferon signaling in systemic sclerosis patients. These findings provide further rationale for that approach.
So it validates that treatment strategy is worth exploring.
It certainly supports it. You know, one of the lead researchers, Dr. Hinchcliffe, used a really powerful analogy.
Right.
She said, measuring this type 1 interferon activity is kind of like assessing the fuel driving autoimmune processes in these patients.
Ah, the fuel for the fire. That makes sense. It suggests it's a core part of what's driving the disease severity in that high-risk group.
Exactly.
Okay, so the implications are really quite significant. But, like all research, this study wasn't perfect. We need to talk about the limitations too.
Absolutely. That's crucial for proper interpretation, and the authors were upfront about them.
What were some of the main ones?
One practical issue was missing follow-up data, particularly at the 12-month point, for quite a few patients in that initial press cohort, the early diagnosis group.
Why was that?
Funding issues, basically. The registry wasn't consistently funded, which made continuous data collection challenging. It's a real-world problem in long-term studies.
Yeah, that's understandable but unfortunate. What else?
Well, remember how they defined interferon high based on comparison to healthy controls?
Yes.
That control group wasn't perfectly matched, especially for ethnicity. And since ethnicity might influence baseline interferon levels, the cutoff score they used, 5.5, might not be the absolute optimal one. Maybe a different threshold would perform even better.
So the benchmark could potentially be refined.
Potentially, yes. Also, it's important to reiterate, they measured interferon activity indirectly using that panel of 6 chemokines.
Right, the smoke, not the fire directly.
Exactly. And while those chemokines are strongly linked to type 1 interferons, other factors could theoretically influence their levels too. So it's a very good proxy, but not quite a direct measurement.
Okay. And what about the need for more research?
Definitely. The researchers stress this. While the findings are promising, this interferon score needs more validation in different patient groups. We need to confirm its reliability and its real-world clinical usefulness.
Like seeing if changes in the score truly track with how patients are doing clinically over time.
Precisely. Does the score go down if a treatment is working and the patient improves? We need to know that. They also noted that some specific analyses, like the survival analysis adjusted for disease duration, involved relatively small numbers of events, deaths. So larger studies would provide more robust results there.
And data limitations.
Yeah, they mentioned a lack of complete race, gender, and ethnicity data across the board, which prevented them from adjusting their findings for these potentially important variables.
Okay, so important caveats to keep in mind. But despite those limitations, the expert opinion seemed quite positive, especially from Dr. Hinchcliffe.
Very much so. She really drove home the seriousness, reminding us again that systemic sclerosis has the highest case fatality rate of all the autoimmune rheumatic diseases.
A stark reminder.
And she emphasized the potential impact of early action. If we catch patients early and treat them more aggressively, we can often prevent bad outcomes.
Which is exactly what this biomarker might help enable.
That was her core point. She said, these are people at high risk, and we really need to be focused on monitoring them closely and treating them aggressively before lung damage occurs. She clearly sees this interferon score as a potential tool to achieve that.
It sounds like she truly believes this could change things.
She does. Her hope is that this high serum interferon score could one day reliably predict risk early on, leading to more personalized, effective treatments. She explicitly stated that being able to potentially distinguish high-risk from low-risk patients with diffuse disease using a blood test represents a large step forward for the community.
And the journal itself acknowledged the promise.
Yes. The editorial published alongside the study in the Lancet Rheumatology also highlighted the potential significance of these findings.
It's also interesting how this fits into the wider context of interferon research in autoimmunity.
Absolutely. The study discussion touched on that. There's growing evidence linking type 1 interferons to the underlying mechanisms of several autoimmune diseases.
Like genetic links?
Yes. Genetic studies have found associations between genes in the interferon pathway and the risk of developing systemic sclerosis. Plus, results from previous clinical trials offer clues.
You mean trials involving interferons?
Right. There was an older trial back in 1999 using recombinant interferon alpha, which, maybe counterintuitively, didn't show benefit and maybe even worsened lung outcomes in some. More recently, a trial with anifrolumab, that's a drug blocking the receptor for type 1 interferons, showed some positive signals in reducing gene activity related to fibrosis, that tissue hardening.
So a complex picture,
Yeah.
but interferons are clearly involved.
Definitely involved. And another interesting point came from the Scleroderma lung study, too. It suggested that patients with high interferon levels might initially respond better to immunosuppression, but if their interferon signature remained high despite treatment, they tended to have worse long-term outcomes.
Wow. So it might even predict treatment response, or lack thereof, in a way.
It could be part of that puzzle, yes. It all reinforces the idea that this type 1 interferon pathway is a critical player in determining the severity of systemic sclerosis.
Fascinating stuff. It really brings together different lines of evidence. Okay, as we start to wrap up, what's the main provocative thought we want to leave our listeners with?
I think it's really about imagining the future. Consider how fundamentally different managing a complex disease like scleroderma could be if we could reliably identify those at highest risk right from the beginning.
Yeah, moving away from waiting for damage to occur towards predicting and preventing it based on an underlying biological signal.
Exactly. How could that change treatment strategies, patient monitoring, even just the conversations doctors have with patients about their prognosis?
It really makes you think about the broader impact of biomarker research, doesn't it? This whole push towards personalized medicine, using these kinds of indicators to tailor care. It holds so much promise.
It really does. And if listeners want to dig deeper,
Well, you could certainly explore the specific roles of those 6 chemokines they measured, CCL2, CCL8, and the others, see how they fit into the immune cascade.
or look into the ongoing clinical trials targeting the interferon pathway, not just in scleroderma, but other autoimmune conditions too.
And of course, the original study and the editorial in the Lancet Rheumatology are out there for anyone wanting the full scientific detail.
This whole area of research is just another great example of science pushing forward, constantly striving for more precise tools to understand and manage health.
Absolutely. It offers genuine hope for improving outcomes and providing better futures for people facing really challenging conditions like systemic sclerosis.
Thanks for tuning in to the Health Headliner podcast by To Digital. Like and subscribe for more health news and breakthroughs. Stay healthy and informed. See you next time.